Okay, thank you so much, Aileen, for the introduction. Very good afternoon to all. Foremost, I would like to thank the organizing committee for this wonderful effort. We hope this course will benefit our colleagues in critical care management. And thank you for the overwhelming response from all the participants. Today, my topic will be on inotropes and vasopressors in critical care. I'll be talking on the common inotropes and vasopressors are being used in our general ICU, in our COVID ICU, and in the care of critically ill patients in other settings as well. There are many various types of inotropes which has been currently used in many settings, but for our topic per se, as it is a basic critical course, we will talk about the most commonly used agents, the 5 most commonly used agents. I'll be starting off with, so these are the 5 most commonly used agents in our general ICU or COVID ICU or critical care settings in the ward. It is noradrenaline, adrenaline, dopamine, dobutamine, and vasopressin. First, we will talk about what is inotropes and what are vasopressors, how they differ, and what is the aim of using inotropes and vasopressor in critical care management. To understand the mechanism actions of these drugs, we will explore into the basic physiology, as in what is mean arterial pressure, how these inotropes and vasopressors alters the mean arterial pressure, and what are the receptors that involve in actions of these drugs. Next, for us to choose the right agent for the right patient, we have to have a principles that guiding the rational usage. There are some fundamental concepts that we have to explore. After that, we will talk about the pharmacology of the individual agents. And finally, we will conclude with practical issues involving usage of these drugs and summary. For an introduction, what are inotropes? Inotropes simply say the agents that increase the force of myocardial contractility. And vasopressors, as the name suggests, vaso for vessels and pressors for contraction. They are the agents that cause constriction of blood vessels, also called a vasoconstriction. The aim of usage of these drugs are to increase the blood pressure and maintain tissue perfusion. So we talk about blood pressure. What is the blood pressure that we are concerned about? In ICU setting or critical care setting, rather than systolic and diastolic, which can be affected by many factors, we are more concerned about mean arterial pressure. What is mean arterial pressure? Is an average arterial pressure during a single cardiac cycle. Simply say by given a formula, I think most of us have learned in undergrad, MAP is equal to 1/3 of the systolic blood pressure plus 2/3 of diastolic blood pressure. The range is usually around 70 to 100 millimeter mercury in adult. The aim is to maintain the perfusion of the organs by maintaining adequate circulation to the tissues. Generally, MAP less than 60 millimeter mercury in adults will cause underperfusion and lead to organ dysfunction. Saying that, what are the factors that affects this mean arterial pressure? Mainly cardiac output and systemic vascular resistance. And the equation by which these two factors affect the mean arterial pressure is given by mean arterial pressure equivalent to cardiac output times systemic vascular resistance. As we have seen here, the heart pumps, which each ventricular contraction, there will be a stroke volume ejected from the left ventricle. This is the stroke volume. And with the each ejection means with the beats of the heart. So the heart rate. So the cardiac output is equivalent to heart rate times stroke volume. Heart rate will be beats per minute and stroke volume will be in milliliter. So we will get cardiac output 5 liter per minute, 6 liter per minute based on the body size and patient's age. Next, we talk about systemic vascular resistance. Systemic vascular resistance is the vessel tone. Either the vessels are vasodilated or vasoconstricted. Based on the properties, they will pose a certain resistance to the blood flow. So your mean arterial pressure is cardiac output times the systemic vascular resistance. Expanding this equation further, the cardiac output, as we mentioned, heart rate and stroke volume. Heart rate is the beating of the heart per minute, but stroke volume is affected by various factors as well. such as afterload, preload, and contractility. Afterload is the vascular resistance for the ejection of the stroke volume, simply saying the force that left ventricle have to overcome before a certain amount of volume of the blood being ejected. Preload is the fluid status of the patient, intravascular fluid status, which is also measured by end diastolic volume, which is the volume at the end of the ventricular relaxation. Contractility would be force of the left ventricle contraction, rather meaning what is the strength of the contraction from the left ventricle that caused the ejection of the stroke volume. Next, we talk about receptor physiology. What are the receptors that involved in mechanism of action of these drugs to exert their outcome? Commonly used agents, as I mentioned, all the 5 agents exert their effects via various G protein coupled receptors, GPCR. Generally, they are known as adrenergic receptors or adrenoreceptors. Why? They stimulate the adrenergic system, or they cause action by altering adrenergic system, which is an autonomic system, can be sympathetic or parasympathetic. But as we are talking about stimulation, we are talking about sympathetic system, autonomic nervous system and sympathetic nervous system, and they are adrenoreceptors. They exert their action via direct or indirect effects on heart and vessel, causing increase or decrease in contractility or vasoconstriction, vasodilatation. So what are the adrenoreceptors that we are concerned about? It is alpha receptors, which is alpha 1 and alpha 2, beta receptors, beta 1 and beta 2, dopamine receptors, B1 and B2, vasopressin receptors, B1. This is not a physiology class, so I'm not going to go into very detailed actions as in how G protein coupled receptors function to cause the effects using these receptors, but we will talk about outcome when these receptors are stimulated. So this chart or this table shows the subtype of receptors and the location where they are present and outcome when they are stimulated. Alpha 1, which was one of the important receptor for us because it causes vasoconstriction. It's present on the vascular wall, and when a drug combines with this receptor as an agonist, it will cause vasoconstriction, thus increasing systemic vascular resistance and increasing your mean arterial pressure. Alpha 1 also causes certain amount of increase in duration of contraction as inotropic effect without increasing in heart rate. Alpha 2 does not contribute much to the maintenance of mean arterial pressure. But beta 1 is very important for positive inotropy and chronotropy. Inotropy is increase in cardiac contractility and chronotropy is the increase in heart rate, tachycardia. Beta 2 mostly causes vasodilatation and thus reduces the blood pressure. So our inotropes does not works in this purpose. Next, we talk about dopamine receptors. Dopamine receptors have a complicated functions and how do they affect. And dopamine works via dose-dependent action. We'll discuss further later. But at higher doses, it also causes peripheral vasoconstriction, thus increasing systemic vascular resistance. And finally, we talk about vasopressin receptors by which vasopressin acts, which is a pure vasopressor, thus increasing the systemic vascular resistance. So, which one to choose? There are many drugs, there are many receptors, and there are overlapping actions. But we have only one aim: maintain the mean arterial pressure so we can adequately maintain the circulation and make sure a proper perfusion to the organs. So how to choose? So whenever we have a confused while we are in a dilemma, we go back to the principle. The principles in management of shock is 2. First, identifying and reversing the pathogenesis. What type of shock is it? There are many types of shock, as in distributive shock, which includes your septic shock, anaphylactic shock, and spinal shock. It can be a cardiogenic shock, which is due to the pump failure, or it can be due to your obstructive shock, such as in conditions like pulmonary embolism, pneumothorax, or it can be purely hypovolemic shock due to the depletion of your intravascular volume. So we have to do a clinical examination and diagnostic investigation to come to a diagnosis. And based on that, you have therapeutic interventions to overcome and reverse this pathogenesis. Next will be correcting hemodynamic abnormalities, such as fluid resuscitation, vasopressor and or inotropes to maintain the MAP, and supportive therapy, such as mechanical ventilation. Again, the principles. So as I mentioned, ultimately, almost all of the shocks causes hypotension and leading to a refractory shock. So first we talk about hypovolemic shock, or in a patient, if the cause is, if it's the cause is hypovolemia that leading to the shock, so we resuscitate the patient with fluids or blood product, if it's an hemorrhagic shock or it's just a pure hypovolemic shock. If it's a pump failure that causing that reduced contractility, reduced cardiac output, then we have to start on inotropes to support the contractility function of the heart. Or if it's a peripheral vasodilatation leading to maldistribution of blood flow, reduced venous return, reduced preload, reduced stroke volume. So then we start vasopressor to make vasoconstriction and increase your peripheral vascular resistance and push back your venous volume to the central compartment. So when we have a multiple drugs with overlapping actions, this is the proposed classification of vasoactive agents. Inotropes and vasopressors are as generally called as vasoactive agents as well. So we have seen 4 different boxes here. This column corresponds to inotropes and this row corresponds to vasopressor. As you see in here, these are inotropes which have either vasodilator effects or vasoconstrictor effects. When an inotrope has a vasodilator effect, it causes inodilators such as dobutamine and mendrinone. Meaning say they will increase the cardiac contractility, but they will cause vasodilatation, thus reduce the systemic vascular resistance. There are inotropes that works with vasoconstricting properties such as norepinephrine, epinephrine, and dopamine. As we talk about vasopressors, there are vasopressors which have inotropic effect and does not have inotropic effect. There are pure vasopressors are the phenylephrine and vasopressin. Phenylephrine is a short-acting vasopressor we use in OT setting, and vasopressin we use in ICU setting for infusion. And norepinephrine, epinephrine, and dopamine has both inotropic and vasoconstricting effect, vasopressor effect. Again, we come back to the same principle and same equation before we go into individual agents. MAP equal to cardiac output times systemic vascular resistance, and stroke volume is affected by your afterload, preload, and contractility. So why do we have to come back to that? Because each agent have a different function altering these parameters. So we talk about noradrenaline, adrenaline, dopamine, dobutamine, and vasopressin. The other drugs such as mentioned in this, such as milrinone, levosimendan are out of this topic, out of this scope for today. First, we talk about noradrenaline. Noradrenaline is a potent vasopressor. At alpha-1 receptors, they work as the agonist and causes vasoconstriction that increases your SVR. At beta-1 receptors, they increase the contractility, thus increases your cardiac output. So it works as a vasopressor and also a inotrope. The dose is 0.01 to 1.5 mic per kg per minute. The vials comes with 4 mg per 4 ml. One vial is 4 mg. So your dilution, either we call it as a single strength or double strength. Where it is a single strength, we use 1 vial 4 mg diluted in 50 ml or 2 vials 8 mg in 50 ml. What are the diluents that can be used? Either 5% dextrose or dextrose saline. Normal saline is generally not advisable because it lacks of oxidative protection. Side effects, it can cause reflex bradycardia, rebound hypertension if the dose is too much, or tissue ischemia if it extravasated, especially if used in the peripheral line. Uses, most commonly a first agent of choice in distributive shock, such as septic shock, or the pathogenesis is mainly peripheral vasodilatation. I think anaphylactic shock after adrenaline, noradrenaline is the second agent in spinal shock to overcome the peripheral vasodilatation as well. Dose calculation. For every inotrope, this formula stands still for calculation of the dose. So what we are interested in ICU is how many ml per hour to be infused for the patient. How do we find that? So the formula would be desired dose. We fix on a dose first, whether we want 0.1, 0.2 or 0.5 mic per kg per minute. within the acceptable dose range. And then time 60 minutes, as we want to convert hours to minute, and then the weight. The weight we take is ideal body weight, okay, and divided by the drug concentration in mic per mil. So how do we come to that? As an example, noradrenaline drug concentration we are taking as 1 vial single strength 4 mg diluted in 50 ml. So when you convert to mic, mg to mic times with 1000, you get 4000 mic in 50 ml. 4000 mic divided in 50, you get 80 mic per mil. Example, Mr. V is 60 kilo ideal body weight, and the desired dose that we want is 0.5 mic per kg per minute. So how do we do it? The infusion rate will be desired dose 1.5 times 60 minutes times 60 kilo divided by the dose concentration mic per mil, 80 mic per mil. You will get 22.5 mil per hour. There are infusion pumps where you don't have to do this manual calculation. You just have to put in the patient's body weight and you put in the dose concentration and mention your desired dose concentration. They will calculate this for you and then infuse accordingly. It's done in ICU settings, the infusion pumps. But if you don't have the infusion pumps as this drug library, you have to do this manual calculation. Next, we go to adrenaline. Adrenaline is a potent vasopressor and inotrope. It acts as alpha-1, beta-1, and beta-2 agonist. Predominantly, beta effects at low dose and alpha-1 effects at high dose. Meaning, at low dose, it predominantly affects as an inotrope. But as in increasing dose, it also causes vasoconstricting effect. Thus, it increases your SVR, heart rate, and contractility as well. Okay. So when you increase your systemic vascular resistance, you increase your heart rate, you increase your contractility, your mean arterial pressure will be increased. The dose is the same for noradrenaline as for the noradrenaline for infusion, 0.01 to 1.5 mic per kg per minute. The adrenaline vial comes as in 1 mg per mil, and the infusion preparation usually either single strength with 3 mg or 6 mg in 50 mil. Either you take 3 vials or 6 vials. It can be diluted in 5% dextrose or normal saline. The side effects can cause tachycardia because of chronotropic effect, can cause rebound hypertension in overdose, can cause arrhythmia, can cause hyperglycemia because it's also diabetogenic, and in high doses, it can cause lactic acidosis. Where it is used, it is the first choice of drug in anaphylactic shock, as in adult, we give 50 mic bolus, and cardiac arrest, we give 1 mg bolus, and also in other shock, as in septic shock as a second choice of agent after noradrenaline, and also in other shocks where second agent is needed to increase your contractility and your peripheral vasoconstriction. Dose calculation, same formula. So the example, we take a drug concentration of 3 mg in 50 ml, 3000 mic divided by 50 ml, 3 times 1000, 3000, 50 ml, 60 mic per ml. This is your drug concentration in mic per ml. Again, the same person, 60 kilo, desired dose is 0.5. So 0.5 mic per kg per minute times 60 minutes times 60 kilo divided by 60 mic per mil, you will infuse the patient at 30 ml per hour. So inotropes, and next we will talk about dopamine. Dopamine is the same as adrenaline, but it does not causes the same effects. It causes the same effect as adrenaline, as in low dose, it causes beta-1 agonist, dose-dependent action, increases cardiac output. At high dose, it causes alpha-1 agonist and vasoconstriction. So increases your SVR. The dose will be 0.5 to 20 mic per kg per minute. The dopamine comes in a vial of 40 mg per ml, which is 5 ml. So 5 times 40 will be 200 mg in 5 ml ampoule. So we either give single strength where it's 200 mg or double strength where 400 mg diluted in 50 ml, can be diluted in 5% dextrose or normal saline. The side effect will be tachycardia, hypertension, and arrhythmia, same as adrenaline. Because dopamine is a potent endogenous catecholamine, it is absolutely contraindicated in pure chromocytoma. Please go and read about it. It's an adrenal gland tumor. And it is commonly used in spinal shock, where patient have bradycardia and also hypotension. So this will causes vasodilatation and vasoconstriction to increase the systemic vascular resistance and also overcome the bradycardia. Calculation, again, same. We want to find out the rate of infusion field power. The formula is the same. So as an example, dopamine, we take a single strength, which is 200 mg, we dilute in 50 ml, 200 times 1000 is 200,000 mic in 50 ml. When you divide it, will come 4,000 mic per ml. The same patient, 60 kilo, desired dose, let's say we want to infuse at 10 mic per kg per minute. So 10 mic kg per minute times 60 minute times 60 kilo divided by the drug concentration of 4,000 mic per ml, you get 9 ml per hour. And then you alter it accordingly. Next, we talk about dobutamine. Dobutamine is an inodilator. It means it causes inotropic effect, but it causes vasodilatory effect. So as a whole, it's called inodilator. It is a beta-1 agonist, which increases your cardiac output and heart rate. It's an inotropy and chronotropy, but it stimulates your beta-2 agonist, causing vasodilatation, thus reduces your systemic vascular resistance. So this is the down part of dobutamine, but the vasodilatation can be used for peripheral perfusion also in a patient who have a severely vasoconstricted state. The dose will be 2.5 to 20 mic per kg per minute. The vial comes in 250 or 500 mg in 50 ml. It means this picture is too small. Each ml, it's a 20 ml vial. Each ml contains 12.5 mg. So 12.5 times 20 ml, you get 250 mg. So you prepare as a single strand or double strand, which is 2 vials. You dilute in 50 ml. Diluents can be 5% dextrose or normal saline. The side effects will be tachycardia and hypotension because beta-2 agonist effect causing vasodilatation. So it's used in heart failure in a patient with ischemic heart disease where the BP is almost sustained and patient is not in a severe hypotensive state. And it could use in a cardiac output augmentation in myocardial dysfunction and other shock, as in like septic shock patient who also have a severe myocardial dysfunction that we need to augment the cardiac output. We use this with cautious in this kind of patient. The dose calculation, same formula. As an example, we take a concentration, let's say 250 mg, 1 vial in 50 ml. So 250,000 mic when we times 1,000 divided by 50 ml, you get 5,000 mic per ml. Same patient, 60 kilo. Let's say our desired dose is 10 mic per kg per minute. So 10 mic times 60 minute times 60 kilo divided by 5,000 mic per ml, you get 7.2 ml per hour. Next would be vasopressin. Vasopressin is a pure vasopressor. It does not have inotropic effect. So it acts at the V1 receptors at the vascular wall, causes peripheral vasoconstriction, thus increases your systemic vascular resistance. As opposed to the other vasopressors we use, dose of vasopressin only comes in units per minute. It's not mics per kg per minute. It's 0.03 to 0.04 units per minute. Each vial comes with 1 ml vial, where 1 ml has 20 units. So 1 vial of vasopressin contains 20 units. So dilution is 20 units in 50 ml. So when we dilute 20 units in 50 ml, you dilute with 5% dextrose or normal saline. Side effects can be rebound hypotension. So when you want to taper it, you have to taper it slowly. If you taper it abruptly or stop it abruptly, patient can have a severe hypotension due to abrupt vasodilatation. Cautious use in ischemic heart disease because since it's a potent vasopressor, vasoconstrictor, it can also cause coronary vasoconstriction, thus causing myocardial ischemia. It is the second agent of choice in septic shock or anaphylactic shock, any distributive shock where vasodilatation is the main pathogenesis. So the calculation of the infusion meal, it differs compared to the others, in which here the desired dose, which is units per minute, times 60 minutes, there is no body weight, divided by drug concentration. So we omit the body weight, everything else is the same. So as we mentioned, 20 units in 1 meal, diluted to 50 ml, you get 0.4 units per meal. Desired dose is 0.03 unit per minute. We are not interested in the weight. So infusion rate will be the desired dose times 60 minutes divided by the drug concentration. You get 4.5 ml per hour. So that if you want to run at 0.03, if it's 0.04, will be 6 ml per hour. Next, we have talked about the physiology, we have talked about the principle, and we have talked about the pharmacology of the individual agents. Now we have to talk about the practical issues in using these drugs. Even though all the drugs that we use in our management of patient are aimed to save the patient or benefit of the patient, there are some disadvantages or some precautionary method we have to look into. So what are the practical issues? One drug, many receptors. So they can have many different effects. So we have to know the pharmacology of the drugs very well before we choose an agent for a patient. First, identify the pathogenesis and choose the right agent. As we can see here, this is the phenylephrine, norepinephrine, dopamine, epinephrine, dobutamine. You can see there is an overlapping of alpha and beta effect and the overlapping of effect on cardiac output and blood pressure. As we see, the phenylephrine and norepinephrine, they have a higher effect on blood pressure compared to cardiac output. But when we go to dobutamine and we go to epinephrine, they have a more effect on the cardiac output rather than your effect on blood pressure. This graph also shows the same type, where it actually shows the inotropic effect and where they stand on vasoconstricting and vasopressing, vasodilatation effect. Next practical issue is volume resuscitation. Inotropes or vasopressors are start after adequate fluid resuscitation. Repletion of adequate intravascular volume is crucial because starting a vasopressor without adequate intravascular volume is beneficial. If there is no fluid to pump from the peripheral vessels, what they're going to pump while constricting it. Okay, so you have to make sure adequate fluid resuscitation is done. Next, selection and fixation based on the etiology of shock. As I mentioned, management of shock, you have to identify the pathogenesis so you can reverse it accordingly. So do a frequent clinical evaluation and titrate the drug because overdose or unnecessary infusion of inotrope vasopressors can cause disastrous effects. When one inotrope or vasopressor have already reached a maximal dose or started showing side effect, try to add on second agent so you can reduce the dose of the first agent. Route of administration. Inotropes and vasopressors ideally should be given via central venous line because rapid delivery and fast effect. Peripheral lines, there are a lot of problems. There is possibility of malfunction, only a temporary, so it's just be used only a temporary use. And if the peripheral line is extravasate, it can cause tissue necrosis. So that is another factor that you have to consider before running a inotropes or vasopressor via a peripheral line. Tachyphylaxis. What is tachyphylaxis? Tachyphylaxis is defined as a decreased responsiveness of a drug over time. When we continue infuse a drug or inotrope or vasopressor for a long time, the response to the drug will come down. So we have to constantly re-evaluate the clinical status of the patient and titrate it accordingly so we don't end up in tachyphylaxis. Next, this is an important thing we have to remember. Not all patients on inotropes or vasopressors are in shock. Many a time we start inotropes or vasopressor, especially vasopressor in ICU, purely to counteract the vasodilatory effects of eye sedation given to ICU patient. As an example, patient on cerebral resuscitation, we want their brain to be in absolute rest. We will put them in a Ricus -3. I'm sure Dr. Vincent have talked about your scale of sedation, everything. When you put a patient in Ricus -3, you will need a very high sedation. So when you have a high sedation, most of the sedative drugs will cause vasodilatation and indirect myocardial depressant function. So that will cause reduction in your mean arterial pressure. To support or to augment this and overcome the vasodilatory effect and myocardial depressant effect, you will need certain amount, a low dose or certain amount of inotropes or vasopressor. This doesn't mean these patients are in shock. Next will be COVID patients. As we are in a COVID pandemic era, most of the COVID patients are being ventilated. They will come with a very stiff lung, very difficult ventilation, very severely restless. So you have to start them on a very high sedation so you can put them into a rest during the hyperinflammatory state and to achieve a better ventilation, to achieve a good oxygenation. So these patients in COVID ICU mostly will start on a low dose and vasopressor to overcome these vasodilatory effects of the eye sedation. And finally, to conclude, summary, this is the chart table that I've adapted from ICU management protocol by Malaysian Society of Intensive Care, which actually summarize all the inotropes or vasopressor which is being used in our ICU with the dose, infusion dose, and their receptor binding and their hemodynamic effects. I have described all these as an individual topics earlier, but this is a summary of the full topic. These are my references. And with that, I conclude my topic for today. Thank you for listening, and thank you for the overwhelming response once again. We really appreciate it. Hope you all benefit from the course today, and stay safe and work smart. Thank you.